Hello, this is Kim Jungle. Today's topic is 6 keys to normal occlusion. This is a journal published by Andrews in 1972. It was a study of 120 casts of non-orthodontic patients with normal occlusion. And the inclusion criteria were as follows. Models selected were of teeth which 1. Had never had orthodontic treatment, 2. Were straight and pleasing in appearance, 3. Had a bite which looked generally correct, 4. In his judgment, would not benefit from orthodontic treatment. 6 keys to normal occlusion were mentioned, which are as follows. 1. Molar relationship. 2. Crown angulation. 3. Crown inclination. 4. Rotations. 5. Spaces. 6. Occlusal plane. Molar relationship mostly refers to angles. Molar relationship. Class 1 molar relationship is normal, but the occlusion may not be proper. His point about molar relationship is the distal surface of the distobuccal cusp of the maxillary first molar occludes makes contact with the mesial surface of the mesiobuccal cusps of the mandibular second molars, and the mesiobuccal cusp of the maxillary first molars falls within the groove between the mesial and middle cusps of the mandibular first molars. As you can see, the occlusion may not be proper, even if the mesiobuccal cusp of the upper first molar occludes with the buccal groove of the lower first molar. Number 4 shows the proper molar relationship, with the distal surface of the distobuccal cusp of the upper first molar makes contact with the mesial surface of the mesiobuccal cusp of the lower second molar. This figure shows that normally occluded teeth demonstrate gingival portion of crown more distal than occlusal portion of crown. Crown angulation is also known as second-order bends or tip. It represents how the long axis of the clinical crown is angled to the line perpendicular to the occlusal plane. In normal occlusion, the gingival portion of the long axis of each crown is distal to the incissular occlusal portion, varying with the individual tooth type. The long axis of the crown for all teeth, except molars, is judged to be the middevelopmental ridge, which is the most prominent and centermost vertical portion of the labial or buccal surfaces of the crown. And the long axis of the molar crown is identified by the dominant vertical groove on the buccal surface of the crown. Crown tip is expressed in degrees, plus or minus. If the gingival portion of the long axis is distal to the line perpendicular to the occlusal plane, it has a plus crown tip. Here it is 95 degrees minus 90 degrees, which is plus 5 degrees. On the other hand, a minus reading is assigned when the gingival portion of the long axis of the crown is mesial to the incisal portion. As you can see in this figure, a rectangle that is angulated occupies more mesiodistal space than a non-angulated rectangle. And this is especially important for the upper central and lateral incisors. Normal occlusion is dependent upon proper distal crown yip, especially of the upper anterior teeth since they have the longest crowns. The degree of tip of incisors, for example, determines the amount of mesiodistal space they consume and therefore, has a considerable effect on posterior occlusion as well as anterior aesthetics. Crown inclination represents the labiolingual or buccolingual inclination, and is also known as third-order bends or torque. It is determined by the resulting angle between a line, 90 degrees to the occlusal plane, and a line tangent to the middle of the labial or buccal clinical crown. In Figure A, the upper incisors do not have proper crown inclination. The crown is lingually inclined, and the root is labially inclined, leading to improper occlusion. Figure B shows the normal inclination of the upper incisors, with the crown tilted labially and the root tilted lingually, allowing for normal occlusion. In many cases, spaces resulting from normally occluded posterior teeth are falsely blamed on anterior tooth size discrepancy. But in fact, these spaces are the result of improper torque control of the anterior teeth. Crown inclination is also expressed in plus or minus degrees. A plus reading is given if the gingival portion of the tangent line or of the crown is lingual to the incisal portion. A minus reading is recorded when the gingival portion of the tangent line of the crown is labial to the incisal portion. In other words, a plus reading indicates a crown labial inclination, and a minus reading indicates a crown lingual inclination. He said about torque of anterior teeth of maxillary and mandibular. Upper and lower anterior crown inclination was sufficient to resist overruption of anterior teeth, and sufficient also to allow proper distal positioning of the contact points of the upper teeth in their relationship of the lower teeth, permitting proper occlusion of the posterior crown. Upper and lower anterior crown inclinations are intricately complementary and significantly affect overbite and posterior occlusion. According to Andrews, the upper incisors have crown labial torque, and the lower incisors have crown lingual torque. Upper posterior teeth have gradual crown lingual torque inclination from the canines. Similarly, lower posterior teeth have gradual crown lingual torque inclination from the canines as well. As already mentioned, tip is the mesiodistal inclination, and torque is the labiolingual or buccolingual inclination. Anterior teeth should have proper and proportional amount of tip and torque. This figure shows the wagon wheel effect. As you can see, for every 4 degrees of crown torque, there is a 1 degree of mesial convergence of the root of the upper central and lateral incisors. In Figure 4, the arch wire is torqued 20 degrees, and there would be a resultant 5 degrees mesial convergence of each central and lateral incisors. But the average distal tip of the gingival portion of the central incisors is plus 5 degrees. So it would be necessary to place plus 10 degrees torque either in the arch wire or the bracket. This mechanical problem can be greatly eased if tip and torque are constructed in the brackets. rather than the arch wire. Hence the development of SWA by Andrews. There should not be any rotations. A rotated molar occupies more mesodistal space, creating a situation unreceptive to normal occlusion. There should not be any spaces, meaning that contact points are tight. The occlusal plane varies from generally flat to a slight curve of SPE or a reverse curve of SPE. As in Figure 13a, a deep curve of SPE results in upper crowding and lower spacing. On the other hand, as in Figure 13, a reverse curve of SPE results in upper spacing and lower crowding. A flat plane should be a treatment goal as a form of over-treatment. There is a natural tendency for the curve of SPE to deepen with time, for the lower jaw's growth downward and forward sometimes is faster and continues longer than that of the upper jaw. And this causes the lower anterior teeth, which are confined by the upper anterior teeth and lips, to be forced back and up, resulting in crowned lower anterior teeth and/or a deeper overbite and deeper curve of SPE. At the molar end of the lower dentition, the molars are pushing forward mesially, even after growth has stopped, creating essentially the same result, which is a deeper curve of SPE. If the lower anterior teeth can be held until after growth has stopped, and the third molar threat has been eliminated by eruption or extraction, then all should remain stable below, assuming that treatment has otherwise been proper. But if there is still remaining growth, and the third molars are in development, the lower anterior teeth need to be retained. After orthodontic treatment, the dentition goes through a process of settling. Intercuspation of teeth is best when the occlusal plane is relatively flat. There is a tendency for the plane of occlusion to deepen after treatment. In most instances, the second permanent molars should be included in the orthodontic treatment to get an effective foundation for leveling of the upper and lower occlusal planes. In conclusion, successful orthodontic treatment involves many disciplines, not all of which are always within our control. Compromise treatment may be necessary when patient cooperation or genetics demands it, but should not be acceptable when treatment limitations do not exist. In that nature's non-orthodontic normal models provide such a beautiful and consistent guideline, it seems that we should, when possible, let these guidelines be our measure of the static relationship of successful orthodontic treatment. Achieving the final desired occlusion is the purpose of attending to the 6 keys to normal occlusion. In clinical practice, patients who possess the 6 keys to normal occlusion have good prognosis. Thank you for watching.